Hello everybody, and thank you very much for inviting me to speak today. It's really weird to be here today. You are absolutely not the typical type of audience that I would be speaking to. I'm normally speaking to groups of nurses and I understand them and they understand me. Or I'm speaking to groups of doctors, and I spend most of my life probably with technologists, which is quite an interesting space to be, but they're not like you either. They're not the technologists that I work with, because I don't think that actually we're that well endowed in terms of our designers in the type of space that I work in. But I'm going to talk a little bit about, I'm going to do two things. I'm going to try to give you some insight into, I guess, my industry. So what's going on in health around digital. And then I'm going to try and give you a little bit of my perspective around what I think is important around UX design in my industry and why it matters very, very much. And why collaboration is a very, very important part of what needs to happen for us. Clicker's not working. Excellent. So I'm Anne Cooper, I'm the Chief Nurse at NHS Digital. I'm going to explain what that means in a second. That's my Twitter handle. I would be delighted if any of you are tweeting. If you'd like to talk to me on Twitter, that would be a really good thing to do. And I'm going to talk about why I think UX design in health is particularly tricky. So that's me. So can you all raise your hands in the air and put your hands down if you weren't, or put your hands up. Put your hands down if you weren't around in the year 2000. What about 1990? Put your hands down if you weren't around in 1990. If you weren't born in 1990, that means. Put your hands down if you weren't born in 1980. Wow. Put your hands down if you weren't born in 1979. It's 1970 then. Ooh, thank you. You can put your hand down at the back. Yay! So that picture of me, most of the people in the room weren't even born when I started my nurse training, I think. The majority of you weren't actually around. And just as a reflection really about how much has changed in that time and how things are going at such a pace. Back then, we didn't even have a telephone at home, let alone a mobile telephone. So how did a nurse of that age possibly end up as the lead digital nurse, at least in theory, for the NHS in 2017? Well, it's an accident, a complete accident. You probably chose to be here. You probably all chose to focus your lives on doing something important around design. I chose to start my life focusing on health and on nursing. And I love nursing and I loved doing that. And what happened to me was in around 1998, 99, I went to work for NHS Direct, which some of you may remember. It doesn't exist anymore. 111 has sort of taken over. And what happened was I was in a room with some nurses, and nurses are very nursey, and there were 6 of us being very nursey. And we were setting up an NHS Direct site. Now, I guess we'd all quite naively gone into that space, and we hadn't really thought about the fact that we were actually going into a technology space. And I remember there were 6 of us, all women, and I remember us sitting in this room and these men kept on coming in and talking to us about telephony systems and software and computers, and we were all like, oh yeah, we're nurses, go away, we don't want to talk to you. But they were quite persistent, and I remember thinking, you know what? When people are persistent like this, usually it's for a pretty good reason. So I started tuning into what was being said, and the rest of them sort of positioned me to the front, and I became the one who dealt with the technology. And that was the start of my career in what would now be called digital, and back then was what we call clinical informatics. And you know, so I didn't choose it, but I'm actually really glad that I'm here. And I'm really glad that I get to spend time with people like you back in my place of work, but also really, really clever people who understand some of the complexity of what it is that we do in health. So what Simon saw that day when his son was being born was no accident. Health doesn't happen in an accidental way, but it does happen in an organic way too. So it's a very complex system. You know, you can't plan. It's not linear. Some of the things that we try to do, we do in a very linear way, but actually it's just quite a complex environment. So that's a little bit about me. That was 1984. That was me as a second-year student nurse, and we wore hats back then. You would never see that now. And I had those photographs taken from my granddad, who was incredibly proud that I was a nurse. So I work for NHS Digital. So who are we? We are the organisation, that's our strapline, to make health and care better by harnessing the power of information and technology. There's two words that are really important there, and sometimes we forget that we do both. One is that it's about technology, but the other is that it's about information. So we collect all of the information that's collected about health across England and social care. That's quite a big deal, and that includes a high level of public trust. So trust is a major issue for us. How do we get people to trust us, trust our brand and have a trusted personality? And how do we do all of that stuff around the technology? So our national, that's our role. So we are a single organisation. There's only one of us, and we support the whole of the NHS in England. We're what's called an arm's length body, so that means that we're quite unique. And we tend to provide the infrastructure and tools and things in the NHS that only needed to be provided once. So you'll have, all of you, in your areas, local things that are developed by the local systems in health. But we provide the big national solutions. Has anybody worked in health? Show of hands, has anybody worked in health? So we provide what's now called NHS Choices. Have you all heard of NHS Choices, which is one of the biggest health websites in the world? People syndicate our content all the time. But we also provide things like the deep infrastructure things. We provide something called the National Spine, which is where all of your demographic information will be held. And if you go to your GP or anywhere like that, they will go and pull the data down about you from the spine. So what's happening currently in health around technology? That's our current ambition, building an integrated, paper-free health and care system. And we've divided that into sort of 10 broad areas of work. And they all have different characteristics. So the first one is the one where I think that we have most of the design UX work going on, because that's our citizen-facing area. So in that space, we've got the NHS Choices replacement, which is called nhs.uk. We've also got things called personal health records, which is where you will be able to access information about you in time. Has anybody got access to their own GP record already? Just a couple of people. It's really interesting because I speak to different audiences, and interestingly, I think it's partly to do with the age of the audience. The older you get, the more chances are that you'll have different health conditions, and the more interested you are in looking at what information we hold about you. So that's what we call Domain A, but we've got other domains that are quite interesting too. So Domain D is all about how we move information around. So how do all of those different systems and interfaces talk to each other? So interoperability is a massive issue for us. We've also got things like Code for Health, which is about open source. We've got a huge range of things. We're quite a broad organisation in terms of the range of things that we do. If anybody has repeat prescriptions, the chances are you'll now be using electronic prescribing, and we provide that system. And so it goes on. The bottom one, Domain H, is where I was talking about the data earlier on. So this is all going on in health. We're an organisation of around 2,500 to 3,000 people. It varies a little bit. Lots and lots and lots of work. Public trust and scrutiny, as you can see, is at the bottom right-hand side. Really important issue for us in terms of... I was talking to somebody the other day who'd looked at some trust sort of stuff. What do people trust? What are people most concerned about around trust? What are trusted professions and so on? And one of the biggest anxieties that was coming out quite close to the top was that the pace of technology and the sort of stuff that you do and I do is raising people's anxieties around the way they live their lives and so on. And that, I think, is a really interesting dynamic when you work in health. This is one of the big ones that I'm going to sort of use as a leap into what I want to talk about next in terms of UX. So you could talk about user experience in lots and lots of aspects of the things that we do. So I could have focused, I wouldn't have done because I'm not anywhere near expert enough, but I could have talked about the public-facing stuff that we do, which is probably closest to the types of stuff that you probably are all interested in. However, I'm going to focus on something which is more about how clinicians like me would interact with systems and what user experience might mean for us. And that sits in this domain. So it's about having world-class technology and systems. How do we find them? How do we grow them? How do we learn from each other in that space? And in order to do that, of course, systems take people, the collaboration, the interface, the arrangements that sit between a system and a human being is really important. So we're having to focus on both of those two things. We're having to focus on the technology, but also the skills of the people that work in our system in order that they can get the best out of the technology, which is another type of collaboration, really. But you know, we are bothered about the empowered patient too. There's always multiple perspectives in my world. There's always more than one perspective on a single thing. And empowered patients, the NHS is under incredible pressure right now. It's under pressure. You'll see it in the media all the time. And everybody's talking about how technology can be used to lever the system. How can we energise and use the power that sits in the population to help us to manage health in different ways? NHS.uk is part of that journey, and again, I would recommend that you follow this site. This is we're supposed to be one of the leading health sites as we go forward, and we've got a great team working on this. But I'm not directly part of that team. But it's so there's something about how do you get the population to take more responsibility for their own health? How do you do that? How do you use the design experience to do that? What is it that you can do to make them feel like you've got personality, that it's not a bland thing that they're dealing with? How do you do that and address Alistair's accessibility issues? How can you do that across a massive, massive population? It's a really, really big challenge. But we have to also measure what we do. We're publicly accountable for what we do. It's not you'll be accountable, some of you, to a shareholder environment. Ours is a slightly different environment, but accessibility and governance still really matters. So we still have to measure the impact of what we do, and we have to show an ROI in a different sort of way. But we can evidence that technology does make a difference in health. And these are some of the slides that we've looked at that were about the time. Time is a precious commodity in health. So that's one of the general practice extraction services, looking at diabetic retinopathy. We've got the referral service, so all referrals from a general practitioner to a hospital, so when you had to go and see a specialist, were done by a letter and on paper. And we've transformed that and made that electronic. And I know that sounds really old-fashioned that we used to do it by letters and envelopes, but it's not that long ago. It's certainly well within my lifetime, probably, even though you're all a lot younger than me, or nearly everybody is, you probably will have been around when we were still using paper, I would say. And digital medicines are one of the things that I'm going to talk about shortly. Medicines are a really important factor in a health setting. So what am I going to talk about? So that's a bit of context, really. So that's context around the health setting, what's going on. So I want to talk to you about what we call human factors engineering. And I'm not sure how familiar you'll be with this or not. And it's a concept that's been shifted from the aviation sector, which is a highly safety critical environment, into health. And it's about using our understanding of humans and how they operate and how they interact with the systems. And it's about safety, productivity, comfort and effective use. Those are the types of things that really matter to us. Now, I stole these slides from a guy called Terry Fairbank, who is the guru, as far as I'm concerned, of some of this safety critical stuff. And I'm sure the slides will be, that we'll be able to release the link, won't we? There's a link to some of his work on some of the slides. I did ask his permission, by the way. So human factors engineering is about the fact that we don't actually redesign humans. We redesign the system in which humans work. So it's not about fixing the people. It's not about training the people. If I hear one more vendor say to me, well, we'll have to train them, I think actually that means that your product is actually not adequate. We can't blame the people for when things are hard. And we shouldn't be counting clicks. Those things are not the types of things that we're actually interested in doing. So, you know, some people might say, well, you know, that's the same everywhere. And I think it is. I think that's the point, actually. I think that good UX design, the principles that you all know about that I'm much less expert in, I don't think they are any different in health at all. I think usability is usability. Good design is good design. And it comes from collaboration, which I'll talk about in a second. But I think there are some things that are slightly different in health. And that's why this type of thing happens. So what you're seeing on here are some snippets of things that generally clinicians, and this is from the States, have said about EHR is electronic health record. This is one of his slides, so I couldn't amend the title. There's a lot of frustration about how those systems work. And that's, you know, we've got some of the best people in the world working on these products and systems. So why is it that we're still getting some of that coming through? Why is it that this is such a challenge? And, you know, you could argue that it's partly sloppy design. You might all say that. And I would say perhaps that's true. But I think there are also other reasons. And one of them is about risk. So we are a very risk-averse context to work in. And that's a pick list of medicines. Now, people have to select something from that list and look how alike it is, look how different it is. And if we don't get the UX design right for that, it could have some fairly serious consequences. So when I talk about UX design being important, I honestly think that poor UX design is such a safety critical issue that it could cause permanent harm or even death to people. It's a really, really important issue for us. So we take it really, really seriously, and we do what's called hazard assessments. So when we're taking a journey through a system, we will deliberately go through and look for hazards that can be mitigated, and we would use the design to actively mitigate hazards. So on that list, for example, what you need to work out is what is the most likely medication that they will prescribe and put it at the top, and make it easier for the user to select the right one. But there's all sorts of different design mechanisms that you can use to try to help users not to make mistakes. And medication and allergies are two of our highest risk areas of work. Collaboration is a really interesting thing because we've Simon talked about collaboration in a birthing room or whatever you would like to call it. This is an ED room, an emergency department room, and they are frenetic. So if you just try to imagine for a second or two what London ED departments will have been like over the last couple of months. How many people were there? What was going on? The risks, the information that needed to flow around the system, and try to think about trying to do UX design to meet that environment. Highly complex, but it is about form following function. This is an example on the previous one. Can you see that they're looking at a whiteboard? As EDs became more and more complicated and busier, naturally they started using whiteboards to help them to do their process work and to share information. And of course, as we move to a more and more electronic environment, it became obvious that we needed to try and make that electronic. So there's quite a lot of people working on electronic whiteboards, as we would call them. And the guy, Terry, did a study of how some of this worked. And that's, hopefully you can see that, that's the type of complexity that we're trying to provide support with. And he highlighted two things on there. So you've got a multidisciplinary team, as we would call it, using this particular whiteboard. So you'll have doctors, you'll have nurses, there's different types of doctors, there's specialists coming down to join the team, there's possibly other people there might be pharmacists there might be radiographers there. They're all coming in, out all the time to use this particular type of resource. They're looking at where their patient is, what's happening with them, where the patient is in the process. It's quite a frenetic environment. But they discovered two things. Can you see that on the left-hand side, there are some red dots? When they did the design to replace this system, they didn't really know why those red dots were there. And I think they didn't know because they didn't really understand or collaborate with the range of people who were using this particular system. And what those red dots were there's some of the ancillary staff who were restocking the rooms used a red dot to indicate when they'd restocked the room. And it's really important, trust me, that you're taking patients into a room that you know has been restocked. But they didn't really know. And of course, they didn't involve those people in the design of the product. So when you're collaborating in this highly complex environment, understanding who your stakeholders are and who your users really are is a really important thing to do. That's the sort of screen that they ended up coming up with, I think. And you can see it looks really good, but it's got some things missing. And one of the things that it's got missing is that there was a symbol on the other screen that they didn't understand on the whiteboard, and it was the one that's there, the circle. And it was an American example, so they used terms that I wouldn't recognise particularly, but the circle was a different colour depending on the consultant that the patient belonged to. One slash through it, I think, meant they'd been seen by the doctor, and the other one meant effectively they'd been discharged by the doctor. And they didn't put that symbol on the screen. So the doctors reverted back to paper and they reverted back to cards so that they knew what was going on, but of course nobody else knew what was going on. And the nurses need to know when patients have been discharged in order that they can help the patient home or to a ward or wherever it is that they're going. What they found was that they had massive numbers of people who were being moved on to the next stage or process, but actually they hadn't been seen by the doctor and discharged. That's a really, really risky thing to do. A really risky thing to do. And that's because when they did their design, they didn't involve everybody in the process of design. So co-design for me is key. That means you have to get the people together, everybody in a room together. And it means you have to listen, listen again, listen. And it's the only way you're going to get it right. And I've been there and I've had to, my job, the type of role that I would have would be to facilitate and to translate the conversations between the technologists and the designers and the groups of people. And it would be me who was responsible for saying, the whole team are not here. There's something going on here that's not represented in what we're trying to deal with. But the point I'm trying to make really is how complicated it is to do UX design in health. It's not, I think, for the faint-hearted. There's something else that we talk about in health, which is you can use design to implement safety by using alerts. So you can use your system as an intelligence system to tell people when something might be going wrong, which is a really, really useful thing to do. But this is how complex it is. Of course, we've now have something in health called alert fatigue, where the system is designed to stop somebody making a mistake, but that particular scenario arises so often that they actually just click past it every single time. So the alert becomes meaningless. The user then just feels like the system should stop telling them what to do. And there's quite a lot of interesting stuff coming out around alert fatigue, around intelligent systems and how you build that into design. Because, you know, our sort of environment is, well, it's not the sort of place where we would allow users necessarily to switch it off. I mean, you might say, well, just allow them to switch it off. But actually, our regulatory way of working means that we probably wouldn't do that. So it's quite a complicated system to work in. I'm going to finish there. So I wanted to highlight two things to you in that bit there. One was around risk. So the type of environment that we work in is really risky. And the second is it's also highly complex. So UX design in this place for me is, and I need you to come and work in health. I need you. I don't want to scare you, but I want those people who are really committed to our endeavour to work there, who understand that it's complex, understand the risks, but still think it's a journey worth taking. We look after millions and millions and millions of people. And I think that's a really social endeavour to embark on working in health. And I think the opportunities for good UX design and system design, it's going to get more and more. It's getting more and more in so I've been working in this particular part of health for around 15 years. And I'm seeing more and more design type stuff starting to emerge. But I haven't talked about patients, and I said at the beginning this is a really interesting area. And one of the things that I'm starting to get increasingly interested in, and we've sort of been talking a little bit about it already, is about empathy. And Simon, again, used those words this morning. And I think when we're working with patients and when we're doing design for patients, it's really, really important that we design with empathy and that we understand personality and that we do all of that. And I'm going to give you an example, and I just love this video, so I show it at every single opportunity that I can. I'm going to show you a video of what I think epitomises for me design done without empathy. Okay, so it's a negative video, and I'll see if I can show that for you.
Another shipping forecast issued by the Met Office at 22:43 on Saturday the 18th. There are warnings of gales in all areas except Trafalgar. The general synopsis at 1800, Iceland 960, drifting slowly east and filling. Low 250 miles northeast of the Faroes 9540 by 1800 Sunday. High Trafalgar 1033, slow moving with little change. The area forecast for the next 24 hours. Viking, North and South Utsira forces.
Is it Chinese? Is it Japanese? James thinks it's Chinese.
This little vase is Japanese, and there are
How could you tell?
well, there are several things that we look at. If we first look at the little band that encircles the neck.
Seriously about that? Do you know? I've never heard.
They say 150 pounds, 150. Any advance in 50? Any advance in 50? 80, 90. 90 pounds. Any advance in 90 pounds? All done at 90.
29% swing.
We are seeing the entire shape of British politics changing before our eyes.
Look at that. It is right up. It's almost breaking our swingometer.
Horrifying column that for the Lib Dems, down 27%.
Viking, northwest 5 or 6, wintry showers, good, occasionally poor. North Utsira, South Utsira, east 40s, variable 4, becoming southeasterly 5 or 6, west 40s, Cromarty, 4th, Tyne, west Dogger.
Noel Wiley, no red line for you as your high scores, but let's see, Noel Wiley, is it right? How many people say?
Serving a captive all on here, 254.
No, I think you probably will. I mean, it comes down. I tell you what, you've got several years of Sundays.
Okay.
I can heartily recommend.
To do the pointless thing of making up names. And that stacks the odds against me.
Yeah, I'm thinking Brown's
Now in winter, the sharks are focusing all their attention on the offshore islands, full of young seals. By watching how the sharks hunt here, Alison has learnt what time of day an attack is most likely.
Here is the general synopsis at 0700 GMT. cow in sea area Shannon, moving slowly eastwards and filling. Sorry, that should be low in sea area Shannon. And now the area reports. Viking, northward Sierra, southward Sierra, rain at times, good. Westerly becoming cyclonic, good. Humber, Thames, Bedford, Leyland, Daff, Dover, Seoul, Haight, rain at times, good. White, Portland, Plymouth.
Now, subway systems from around the world. Will you either tell us in which city systems, please? Best of luck.
Okay, let's reveal our 5 subway systems, and here they come. We have got that made you think Paris. New York City from Andy and Julia. 50. David and Rachel are going to say. Is it going to be 15 though? It does do that. 7. Very well done indeed.
2 good answers. I think made this at so many films and what have you, isn't it? Now, A is London.
Chink of light getting inside the telescope. The astronauts had to get the latch to lock.
If you copy, Jeff's just working, putting the doors back together and thinks he seems to close the gap. And we're going to press on. If you've got a way to do it, do it.
Trap and a ratchet. Floating Story Musgrave improvised a solution. It was a success. The astronauts were elated.
Design without empathy. That's what we need to avoid. Thank you very much.